let's get started. So let's define a clinical academic. It's someone who is a healthcare professional who who practices both clinically and conducts investigator-led research. So it's more than someone who may recruit patients for a study that's developed by someone else or by industry. So it's someone who's actually developing the research, asking the questions that they think are important. And of course, if you're going to do that, it requires a good deal of training, and there have to be opportunities and an infrastructure to support that. So you tend to find it in big institutions like Cambridge University hospitals, although we do reach out and try to build that clinical academic workforce across the DGHs and other hospitals that are in the region. Since 2006, we have had a National Institute of Health and Care Research, or NIHR, and part of their commitment is around this capacity building, so developing clinical academic careers. But there are also other development opportunities through healthcare charities, through the research councils, the Medical Research Council, and so forth. And they tend to focus on fellowships to help people gain the experience they need to become an independent investigator, but generally focused on a particular area. So the British Heart Foundation would do cardiovascular disease, the Stroke Association, Diabetes UK, and all of that. So there are a number of fellowship opportunities. Here's a little bit of history. So clinical academics have been something that's been present in medicine for quite a few years. There's always been that tradition around the physician scientist, if you like. But there has been concern, and in 2005, this was before NIHR, there was concern that fewer physicians were going into academic medicine. So they were choosing to practice completely and maybe having private practice as part of their NHS practice, or just not wanting to engage in kind of being a clinician scientist or doing research as part of the time. And so that led to the development of an integrated academic career path where there are a number of opportunities where someone in medical school could choose to do a PhD as part of medical school. They could do it after medical school. And then there were a number of steps along the pathway. This is now called the Integrated Academic Training, or IAT, for physicians. And you can see that there are different opportunities for physicians to start this type of career. So a medical school like Cambridge will have a lot of research that's built into what they're teaching during their foundation year. So after medical school, their initial couple of years of training are called foundation program. They can have some rotations where they're doing research. They're put with a research group. They can also apply for academic clinical fellowships. Now, these can be part funded by NIHR. They can also be funded by other entities or the NHS itself, but they're to provide, again, some experience in research. And this is generally done as a pre-doctoral or pre-PhD or MD degree experience. And then the clinical lectureships and senior clinical academic appointments. So this is all about building people's expertise, and it can take place at different points in their training program. For nurses, midwives, allied professionals, pharmacists, psychologists, it's a little bit different. There's not as strong a tradition, if you go back in history, of a clinician scientist, or of someone who both practices clinically and conducts their own research. But it has been there, and there was a recognition that if we really want to improve healthcare, then we need to support all healthcare providers who want to do this to be able to become a clinical academic, because every profession needs evidence for practice, and there are certainly different questions and different perspectives that are important that we ask. And so a task force, it was the NHS plus higher education institutions were convened, and they came out with a report that recommended a similar type of clinical academic pathway for what I'm going to call NMAPs, which is nurses, midwives, and allied professionals, but very broadly speaking, allied professionals. And as a result of that, the NIHR, with some funding for what was then Health Education England, funded a fellowship program specifically for NMAPs, and I'll show you more about that. And that pathway is not called the IAT, it's called the Integrated Clinical and Practitioner Academic Pathway, or ICA. There are a lot of acronyms in NHS and NIHR, as I'm sure you all are very familiar with. And that over the last 15 years has been further developed into a very robust pathway. So NIHR is our prime funder of research in the UK, and of course, its mission is to improve the health and wealth of the nation through research. And as part of that, there is this huge obligation or commitment to building capacity, so attracting, training, and supporting the best researchers. This started out as talking about training, but in 2018, they launched what's called the NIHR Academy, and they thought that kind of being part of an academy rather than a training program would be something that people would consider much more positive. So it's really a change in name. But it is, the academy is those that are being funded by NIHR for at least 20% of their salary over at least a year are part of that academy. So it's people that are funded through projects and through fellowships and other sorts of things that the academy does. And so it's really trying to bring together that network of clinicians who are engaged in research and continue to support them so that they build very robust programs of research. And there's a whole rather complicated structure that I won't go into. But if you look at kind of the things that the academy does, as you can see here, it's about training, it's about managing those national competitions for fellowships, coordinating the whole academic training program that is funded by NIHR, and developing the skills of the next generation. So they're really looking across, starting very early on to much later, and how we develop clinical academics. So it's a complex landscape, and you can see by this, and this is actually what they've done in the last few months to try to simplify their training programs. So this is the backbone of how NIHR supports the development of clinical academics. So it's the training and ongoing development. So let's just start from what would be the left hand. Under research training, in that kind of aqua-colored column, these fellowships are for anybody doing health and social care research. So you can be a statistician, an epidemiologist, a nurse, a physician, but it's really their workhorse, if you like, of fellowships. It's for all professions, as long as you're doing the type of research that NIHR is interested in, which has research for patient benefit. So they don't do basic science. They don't do very early translational work. It starts with predoctoral fellowships, but those tend to be very focused on methodology, so it's very limited. The main fellowships are doctoral, so someone who wants to do a PhD. And then postdoctoral awards, there is a Development and Skills Enhancement Award, which is not exactly a fellowship, but it is support for training. The advanced fellowships, which actually range from, you can go from very early postdoc to someone who's much more independent and really establishing themselves as a more senior investigator. So there's quite a range in the advanced fellowships. And then the final bit is at a very high level, you can go for a professorship, the research professorship. The next column, which is in yellow, is the one that is the ICA. So this is specifically for health and social care professionals, except for doctors and dentists. This does have a pre-doctoral fellowship, and that's called the PCAF. It also has, and then the doctoral, which is called a DCAF, and then the ACAF, which is the advanced. And so it really mirrors what you see in the first column. So a nurse can apply for a doctoral fellowship through NIHR, or he or she can apply for a doctoral fellowship through the ICA pathway. You can see that it doesn't have the more senior level research professorship. So they would need to go to NIHR, to the other scheme for that. And then the IAT is the kind of nice salmon color there. It is specifically for physicians and dentists. And that is, as you saw on the other slide, the academic clinical fellowships. They also have something called an in-practice fellowship, and then the clinical lectureship. But if they want to do a PhD, they would apply for a doctoral fellowship through that ACWA side of it. So I know this starts to sound rather confusing, and I can tell you that people that are looking for opportunities do find it a bit confusing trying to navigate this landscape of what's available, what am I eligible for, what can I apply for. And then they also have a support for those in local authorities. So it's slightly different there, but more focused on social care. And then there's a lot of, I'm not going to go through all of this on the slide, but there's other types of support, because NIHR is really very much committed to how do we get people into these clinical academic pathways, because they see it as so vital to us moving forward, finding new treatments, finding ways that we can better deliver treatments. And the UK has kind of punched above its weight in a lot of ways in healthcare research, and we want to keep that going. So there are, they're kind of short-term placements. There's things that they do to try to inspire people when they're in school and their training programs, so support for students, and then different types of capacity building opportunities. And certainly looking beyond the UK, also doing some support for more global health initiatives. The other thing that you need to know about how NIHR helps to build capacity is that it does this through its infrastructure support. So the NIHR supports, obviously funds research grants, a lot of different types of research grants. It supports the fellowships that I have just been showing you, which are investments in people, but it also funds a number of infrastructures. And of course, you're all familiar with the Biomedical Research Center at Cambridge, and that is one of 20 centers, but the BRC is one of the infrastructures that is funded by NIHR, and there's quite a few others. There's schools, there's also the Applied Research Collaborative, as we also have here in the east of England. So all of these then have as part of their remit capacity building. So they're set up to help support at a more local or regional level, getting people into these national fellowships and really supporting to build capacity. And I am currently the clinical academic development lead for the BRC. I work with a team of others, and I'll be transitioning that leadership over to someone else. But I'm going to tell you a bit about what we do in the BRC to help build capacity. So we have to write a strategy that goes to NIHR, and ours is around how we can mobilize the resources that we have available and also work with partners, and how we develop that next generation of research leaders. And that is among healthcare scientists, physicians, nurses, midwives, allied professionals. We want to find the best people that are in kind of both Cambridge, but also within our East of England region, that can then become these research leaders. And oftentimes, for someone to be competitive for a national doctoral fellowship through NIHR, they don't do that just, on their own. They're going to have to be supported They may need some time out of practice to do that, and also to have people around them that can help them to write a good application. So we're developing the next generation. We also want to make sure we widen participation. So our work is around looking for, making sure that we support diverse and underrepresented groups, whether they're non-medical. Some of the work we do is around those, making sure that medical trainees from less research active medical schools, so the new medical schools don't have the sort of research background that Cambridge does. And so we need to make sure that they have those opportunities in foundation year or other opportunities to be exposed to research, and to make sure that we're obviously that we are supporting without consideration of gender or background. We don't do it by ourselves. We partner with the ARC East of England. We partner with other NIHR entities, our universities, with NHS England, which was formerly HEE, which we have been running a regional NMAP research training program that kind of fits in between and helps to support people to get fellowships. We work with industry, we work with the academic training offices, and certainly with Addenbrooke's Charitable Trust and other charities. And so our support is around how do we make it happen across kind of pan career. So making sure that we're ensuring there's early research experience so that people get a taste for research. They figure out whether they're even interested in it, whether it's something for them. So we fund with ACT, the Addenbrooke's Charitable Trust, fellowships for healthcare professionals, physicians, nurses, and so forth, where they can take some time out of practice. They can work with supervisors, maybe do some pilot work, do some of their PPI, do their kind of literature reviews, really think about it, and then put in a competitive doctoral fellowship. We've provided some support to the regional NMAP internships and bridging programs. We've helped fund the research experience for the foundation year physicians, and we fund chief nurse internships, which has been a new initiative started at Cambridge University Hospital, which is about getting early band 5, early band 6 nurses and AHPs together, a small group of them. They work with a leader and they do some research as a group that is of a priority to the chief nurse. We also co-fund PhD fellowships, so we're not totally dependent on NIHR. So we're doing that. We help support one that's mostly supported by the Wellcome Trust, so that's another charity we work with. We can do this with charities, with industry and other charities. We do some postdoctoral bridging funding. So as people, one of the challenges is when you finish your PhD and you go back either into a training program or back into your clinical role, how do we ensure that we can keep you developing as a researcher, because the NHS is really just keen to get you back into clinical practice. And then we fund some postdoctoral and early career mentoring and other opportunities such as training programs and so forth. And then we do a lot of networking and conferences and things like that. So if you're involved with some of the patient and public involvement, you will see these fellowships. They will have these kind of funny names like DCAF or just DRF, Doctoral Research Fellowship. They might come from MRC or Wellcome or NIHR, so there's a lot of those. Pre-doctoral and doctoral fellowships, the real focus is on someone's training and development. They're not likely to be doing a clinical trial unless they've been working closely with a research group this is part of a larger program of work. They mostly do developmental work, a pilot or feasibility study. PhDs are 3 years full-time, but some people will take it part-time up to 5 years. And of course, they need to have really substantial patient and public involvement and engagement. And so that's something that is part of that learning process. And NIHR takes it very seriously, of course, and there are patient representatives that do review fellowship applications and sit on the fellowship panels. The advanced fellowships, that should be a much more mature researcher, although they're still in their training and development, particularly if they're early postdoc. Again, PPIE is incredibly important to NIHR and to the charities, but you should see increasing complexity in programs of work. The funding can be for up to 5 to 7 years. I think some of the welcome postdocs are up to 8 years of funding. So it's really is a huge support to the people to develop themselves as an academic. So you will see that investigators have different levels of experience. They're expected to engage with patients in public, but they won't always know how to do that very well. So that's part of their learning curve. So the initial question was, is this value for the NHS? And of course, I have a very biased opinion. I think that if we don't have clinical academics, who's asking the questions that arise from practice? So a clinician knows what those questions of importance are to practice. They will know where the gaps are in evidence. So we're practicing based on, evidence. Maybe it's 10, 15 years old, or it's, we still don't know. And yeah, there's this one study, but do we have the right evidence to make a change in practice? And because they are engaged in research, they're more likely to keep up with the research. They're more likely to practice according to best evidence. And it's a very old study now, but there was a study that said it takes 17 years for research findings to be implemented into practice. Now, that's a gross generalization, because sometimes things happen very quickly with some of, as you might know, with some of the drug trials. But it can take a long time for things to really change. And we've got to shorten that time, because 17 years is too long, because by then we may have learned something else and it has changed anyway. So clinical academics are more likely to be key opinion leaders because they come across as knowledgeable. They've kept up with the research. They've kept up with the latest. And so they have the potential to really influence what happens in practice. They're more likely to be innovators, again, because they're always thinking and reading the research, asking the questions, and to make sure that those research findings are implemented if it warrants. The challenge is always clinical time versus research time. And we all know the challenges that are facing the NHS, that we have long waiting lists. If someone is conducting research for half their time, there's always that pressure on, can't you do one more clinic? Can't you do another shift? We really are short. We've got to be able to, we're having to cancel surgery. So there is this real tension about how we manage that. And I think medicine has done a better job with it, because usually these are well-established programs. We have things like the BRC, which has been largely medical, and now increasingly a broader church. And people can see that it's important that we do everything from the basic science to understand key processes happening inside the body, so that we can then perhaps find new drugs or new treatments to address that, to perhaps prevent or to better treat certain diseases. We also know the importance of new drugs that come along. But there's also a number of questions about, in public health and other areas, how do we prevent conditions? How do we get people to change their behavior if that's in their best interest? What do we know about physical activity and diet and those sorts of things? Because they're actually incredibly important. It's been more of a challenge, and most of my time, I work with medics as well, but most of my time is spent developing capacity among nurses and allied health professionals. And that's a tougher sell, because there hasn't been that rich tradition of the clinician scientist who's a nurse or an AHP. And even though we have these funding streams, nurses and AHPs go into research at a later time period. So the medics have this long training period after medical school. And so it's a little bit easier if they step off and on their training program. I'm not going to say it's always easy, because sometimes they have to delay. But it's much more accepted. They're in their training, and now they're going to take this 3 years out to do a PhD full time. Then they go back into their training program. But a nurse who is a specialist nurse or a consultant nurse or someone oftentimes in a very senior position, even if they get funding for a fellowship, they're not easy to backfill, because there's someone that's in a specialist clinical position or has a lot of responsibility. So it is more of a challenge in how we get managers who are, working very hard to deliver the service in their ward or their unit, to understand that there is a value to them if they've got someone who goes and does a research degree and comes back. And it's about how we then don't waste that investment, but help people to work through and develop themselves. And we want to show how important it is that the research that they're doing, so that it's bringing something back. So it's not just that they can deliver the clinical service, but that they are bringing this research and answering some important questions. So I'm going to beg your indulgence a little bit, and I'm going to take just a few minutes and talk about some of our nurse and allied professional researchers. I would say we have about 12 clinical academics at Cambridge. And so we have really supported people to get these fellowships. So the first one I'll talk about is Peter Hartley, who is a physiotherapist, and he's done a number of things, as you can see here. So NHR used to fund Masters in Clinical Research studentships. They no longer do that, but we had several people that went through that program. He had an ACT BRC fellowship, and during that time, he developed a doctoral fellowship for Dunhill Medical Trust, and that was successful. So he did his PhD. His interest has always been in how we prevent the loss of muscle strength and function in hospitalized older patients. So if someone loses a lot of strength and functioning, perhaps they lived independently before, but now are no longer able to live independently. So it's really important for their well-being, and also for helping people to get home and out of hospital. He's currently a junior research fellow with the Health Improvement Studies Institute and Homerton College, and he has other funding. He has one of the NHR Development Skills Enhancement Fellowships. He's also working with industry to look at how we can better monitor physical activity, and right now starting to develop and test some interventions to increase appropriate physical activity among patients who've had a stroke, and then looking at post-discharge rehabilitation and stroke. So important things for getting people back to the level of functioning that they want. Andrea Lake is a diabetes specialist nurse. She currently is finishing up her DCAF, so her NHR doctoral fellowship, and her interest is in how we can prevent hypoglycemia, but also rises in blood sugar as well in patients with diabetes who've been admitted to hospital, because oftentimes the inpatient diabetes team isn't called until there's been a problem. Someone's had really out of control blood sugars or become hypoglycemic, and she's looking to develop something that is a lot more proactive that will prevent these complications. Just really quickly, Ping Lian is a vascular specialist nurse, and she's very committed to how we can improve the care for people who have venous ulcers, which are common, can take a very long time to heal. We know how to treat them, but what happens is we're not really implementing it in practice. And that's kind of the subject of her DCAF, is how we can make sure that appropriate evaluation and therapy is given for people with venous ulcers when they come into hospital. David Young is a pediatric physiotherapist, and most of his work has been with children who've had trauma, particularly brain injury, and oftentimes they need to continue rehabilitation at home, and that's generally done by the parents. But if they return to different communities where there's not much support, he's looking at how we can have an app and support for parents so they can continue that rehabilitation at home. And there's a whole host of others that I'd love to tell you about, because I think the work they do is so fantastic, and is so important for the health and well-being of patients, and wider than that. But I'm going to stop there because I've been talking for about half an hour, and you may need to stretch, and hopefully you've got some questions.